Everybody. Good evening. Thank you very much for joining us, and I guess I should say happy holidays. I hope everyone is well. For those of you who don't know me, I'm Lisa Machado. I'm the Executive Director of the Canadian CML Network. We're based in Toronto, but we have some support groups in Ottawa as well as in Western Canada, and hoping to set a few more up. Sorry, that would be my puppy who doesn't know when to be quiet. As all of you know, I've got also on the line with me here tonight is Dr. Jeff Lipton. He's our CML expert here in Canada. Thank you so much for joining us, Dr. Lipton. As we all know, we're coming in the tail end of COVID-19. Sorry about the noise here. And we have a ton of questions about the vaccine, about the virus, how it impacts the CML community. I wanted to turn it over to you, Dr. Lipton, to sort of give us an update of what COVID-19 has looked like for the CML community in the last few months.
Okay, well, I guess the first thing is, I guess we're not at the tail end of anything. I'm not so optimistic. I think this is going to go on for a long period of time for a number of different reasons. I think in Canada, we're very slow, although we've been promised all the doses of vaccine that have been ordered. It's very slow in being delivered. Give you a good example. I was on a conference call with Jorge Cortez, who many of you know of. He received his shot Friday afternoon. My son, who's a hematologist oncologist in Michigan, got it yesterday. And right here, we don't even know when our frontline workers are going to get it. So, millions of shots available to us as Canadians, and who knows when we're going to get it is another issue. So let's look at it, the impact of COVID on CML, and is it unique to the CML population? And that's a really good question. From a personal point of view, I have yet to have one of my CML patients who I know has got COVID. I know one of my transplant patients has, and one of my fellows has when he went back home to Europe a few months ago to visit. Other than that, I have no first-hand experience with any of my patients. The International CML Foundation, as many of you know, is a group centered in Adelaide, Australia, and a group of us around the world, maybe about 30 or 40 of us, have been trying to track COVID in CML patients in various countries. And we've now tracked close to 300 patients around the world who have had COVID, who are CML patients. I think there's some fundamental things here. It does not appear that the frequency of COVID in CML patients is any higher than the general population, number one. Number two, it does not appear that the intensity or the disability or the life-threatening aspects of COVID are higher in the CML population than they are in an equivalent risk factor normal population. We've seen in the CML population about a mortality rate of about 12%. Majority of patients have recovered from their COVID. What is interesting in the Western world, North America, Europe, Australia, there have been no deaths in anybody over the age of 60. The deaths in the CML populations have occurred in third world countries. In the Western world, obviously older individuals with comorbidities are higher risk for getting COVID and doing unwell with COVID. And we've seen the few deaths in the Western world, particularly in Europe, have occurred there. Now, I'll be frank, this is a very slanted population. There's places like the United States that have not contributed very heavily to this. There's countries like France and Italy which have contributed to a much greater extent. So it is a biased population. But from what we see, in Canada at any rate, everybody in Canada seems to have recovered when they've got it. We now have about a dozen patients in Canada who've had it. And no one seems to have done unusually badly about it. So that's really the status of COVID, at least with the CML population. Obviously, we do not have a total patient control or registry in this regard. I'm wondering if down the line we may see this in countries like Sweden, which has a national registry which includes every CML patient and every COVID patient. And we'll be able to see a bit of a linkage between actual people, CML, and COVID in an entire population. But this is what we understand. Now, in terms of vaccines, as we all know in Canada, there's a number coming down the pipeline. A couple have been improved. The Pfizer vaccine, which is a difficult vaccine to handle because it has to be stored at -70, is only being distributed in a couple of centers. And the people who are getting this are people in long-term nursing home, old age home facilities, and their caregivers who have been brought into the major centers to get that. To my knowledge, vaccination has not gone beyond that. But we only have, a limited number of doses of that vaccine has become available in Canada versus the more than 20 million that became available in the United States. The second vaccine, which will be coming out, will be actually going out of the major centers into smaller communities, particularly in Indigenous populations for that vaccine. So again, when our frontline workers, whether the emergency room staff, ICU staff, ambulance workers, teachers, etc., are going to get this, I don't know. I think the next line people are talking about is primarily distributing to those individuals and then subsequently working on individuals in the 80s and then the 75 and up and then 70 up and working down. So again, age may trump risk. Do I think CML patients are at more risk so they should have a priority? Well, there's nothing to indicate that. So I'm not sure what that's going to happen. Do I think CML patients should get vaccinated? And the answer is absolutely yes, with the first vaccine that becomes available to you. Do I think it is safe? I think it is. What we've known so far is that, yes, we have some reports of a few allergic reactions in Britain, but generally we've not seen a lot of major reactions. And given the risks of COVID and how this will probably explode in Canada in the next few weeks, given the fact that surveys have shown that people do not intend to behave properly over the holiday season in terms of mixing with others, I think we're going to see it exploding. We're going to see a lot more people getting sick, a lot more people going to hospital, a lot more people going to ICUs. I really think if you get the opportunity for vaccination, jump at it. I think the risks of not getting vaccinated far exceed the risks of getting vaccinated. In order for it to be effective, something we call a herd effect in the country, the estimates are that 70-odd% of the population, perhaps more, has to be vaccinated before we'll see an impact of that. So that's going to be an issue. I'm a little nervous for a couple of reasons. Just in seeing patients in my own clinic, a couple of things are happening. Number one, I'm seeing patients who are not keeping appointments, not getting blood work for follow-up for their CML, and that is not without risk. And they're not doing that because of fears of COVID. For instance, my hospital has, to our knowledge, has not had a single case of a patient who's contracted COVID from coming into the hospital. We've had a couple who've contracted on the outside, a couple of staff on the outside, but no one on the inside. Yet I have patients refusing to do the appropriate blood work, refusing to be seen when they need to be seen. The second thing that's really concerning me is a crude survey of my patients have told me that more than half don't want to get the vaccine because they're not sure of its safety. They're not sure of its impact because they have CML. A lot of them are seeing a lot of myths that are online that the vaccines are going to get into their DNA and do something, particularly if they have CML. It's really scary what I'm hearing from people. Other issues, how long will immunity last? If you get vaccinated, we don't have the answer to that. It will last at least 6 months. And it still appears to be going strong beyond 6 months. Will it protect all variants of the virus? Well, to our knowledge, yes. There's all sorts of things out there on the world stage right now about variants, COVID viruses being out there, and maybe they're riskier in Britain, particularly coming to Canada. I have heard reports from some of the people who've tested the original vaccine that the vaccine will work against the variants as well. So that's really where we stand in terms of CML right now. And beyond that, I can't really say. Obviously, we don't have the experience.
Do you have anything good that you can say? I'm feeling bummed now.
Well, what do you mean? Well, I think we have vaccines out there that are going to protect people. That is good. We didn't have that before.
True.
So I think the fact that once they get to us, I think it'll be quite a boon. I think as I said, I'm disappointed how fast they're getting to us, but that's another issue. I think what's disappointing is people's attitudes, and whether it's ignorance of the benefits of vaccination and isolation and distancing and seeing that, or people are just COVID burned out, or I'm afraid there's an awful lot of people out there who are just selfish about what they want to do. Yeah, you may be young and don't think you're at significant risk for serious disease. Or I just heard today of an 11-year-old getting admitted to ICU at sick kids with COVID, so it can hit little ones as well. But you're exposing other people at risk just by doing this. And we still hear, I've seen parties and people gathering in groups in close quarters and things like that. I think that has to be watched. I think if you're going to be bummed out, I would be bummed out at people's attitudes rather than what is going on.
Totally. I agree. I'm just kidding. I'm just hoping you might have something, a little bit of, some light at the end of the tunnel. I mean, so you're thinking.
I'm thinking.
So you're thinking that we'll have access to the vaccine in September, probably? You think?
I'm hoping people will be vaccinated within the next 6 months. It depends how fast we can get it and how fast we can set up the infrastructure for being able to deliver the vaccine. I think very much will depend on which vaccine we get as to where it can be stored, etc. So if all we're going to get is the Pfizer, which has some storage issues, it's going to limit the number of people who can get vaccinated for obvious reasons.
So if you have CML or even another cancer that's not quite in remission yet, is there a risk to having the vaccine? Like if you're getting chemotherapy?
It doesn't. Remember, we're not dealing with live vaccines. These are not vaccines from which you can get COVID. It's just like the flu vaccines. You can't get the flu from getting a flu vaccine. You may feel like crap, and that's just your immune system turning on to whatever you're getting injected with, which is probably a good sign. So I think if you have another malignancy, have CML, you have a fair bit of risk if you get COVID. But it's not clear that you will have a risk if you get COVID vaccine, regardless of the type of vaccine. And as we all know, there's different types of vaccines, whether they're RNA-based or other things. There's some very unique ones being developed as well, too. There's a company in Montreal developing a Canadian one, which is plant-based, which might be very interesting. But that's at its very early stages, and I'm not sure how fast that will get us anywhere.
Okay, so I'm going to start firing off questions to you. Some people have sent questions in before, so I'll mix them up a little bit. So one of the questions here is, was there any study on whether or not we should get multiple vaccines? Are they complementary to each other, and how do they work? I'm assuming that you would only get one COVID-19 vaccine, right?
Oh, getting multiple COVID vaccines. None to my knowledge. I think most of the vaccines are 2 injection vaccines, and I think they think you should get the same one each time. I'm unaware of any study getting, and by the time you would get a second vaccine, checks and balances on who gets what might be a very long time.
And okay, great. Someone wants to know if your office, would your clinic be giving the vaccinations, or is this something that we're getting in our GP's office?
When The vaccines we're giving at my institution right now are in the Michener building, which is nearby. And this is for the long-term residents and their co-workers. So they're coming there. I don't know how they will be giving out the vaccines, whether they will be distributed. My clinics, generally, the only vaccines we give are vaccines to transplant patients and only one type. So I would doubt that my clinics will be giving these vaccines.
Okay. We have a trial question. Were there who were the vaccines trialed on, I guess? Healthy people? Were there people with cancer?
I think most of the initial trials were probably done on healthy individuals. That
Okay.
keeps the playing field level and keeps things clean as their problems. They probably were not on individuals with malignancies or anything like that. Now that the vaccines are being given out to different people, I expect a lot of individuals with underlying medical problems are going to get these vaccines. Obviously, they're giving them out to older individuals in nursing homes who have a lot of comorbidities, a lot of other diseases, kidney disease, diabetes, lipid problems, heart disease, etc. And as yet, I'm not hearing significant problems in that regard.
Okay. And have you heard anything about prioritizing the vaccine for people? So obviously frontline workers and long-term care homes, but after that, people with cancer.
As I said, the only thing I've heard of in Ontario, and I can speak of there, I gather there's a little bit of difference between provinces. I've heard that, for instance, Quebec is giving it a little different, and Alberta, I think, we're the only other province, and British Columbia are giving out slightly different priorities. In Ontario, it appeared that the Pfizer vaccine, as I said, is the long-term facilities and their care workers. And the other vaccine that's coming out, which is an easier storage facility, is going out to the Indigenous population first. And after that, I have not heard of the priorities that the provincial government is giving, at least in Ontario, and it may be different in other provinces.
Okay, we've got a question from Sid. I read that Sprycel has a moderate interaction with both vaccines, which reduces its effectiveness. Is that true?
I don't think we have any knowledge of that regard. And I don't know where that information came from. That someone may have come up with that. That's a theoretical thing, but I'm not sure that that's been tested in any way.
Okay. And so if there came an opportunity to have both the flu vaccine and the COVID vaccine, would you have both?
If to have which vaccine? The
flu vaccine and the COVID vaccine.
Well, I hope everybody's had a flu vaccine by now, because we're well into flu season.
And but there's no impact.
I don't think there's any impact. I think it's very interesting that the number of people who previously might not have got vaccines who have got flu vaccines this year is quite dramatic. So I think that's an indication. Definitely get both. They cover two different things.
Okay. And would a vaccinated individual still carry the virus, even though the individual might not get sick? So maybe that might be a spreading question.
No, I don't think if you have the immunity against the virus, you should destroy the virus almost immediately on getting it. So I don't think you could be a carrier.
Okay.
Now, if you've been vaccinated, if you've been vaccinated and don't get immunity, remember the vaccines, the stats show are about 95% effective. If you're one of the 5% and maybe don't get immunity, then it is possible you may carry them. So being vaccinated does not 100% guarantee you immunity.
And I suppose we won't know that until people start getting vaccinated.
Well, I think at this point in time, there's no way there's going to be random testing to see who actually gets it. I think the answer will come is if we start seeing COVID infections in people who are vaccinated and know it's either they didn't get immunity or it's breaking through for some reason.
Mm-hmm. Okay, we have a question from the United States. Is there a link to report CML and COVID-19, or I guess COVID-19 in CML patients? How do you guys
In
report?
the United States?
Mm-hmm.
To my knowledge, I don't think so. And as I said, reporting of COVID and CML through at least the volunteer group has been very sparse. I think there's probably been the same number of people in the United States reported as in Canada. It's all voluntary by the physicians taking care of the patients. So I don't know the legalities. I don't think so, at least in discussions with my son who is in the States who treats CML. But
Okay. Okay, from Judy, if you have a consultation regarding options for a BMT, so bone marrow transplant, should you postpone getting the COVID vaccine?
if you're just having the consultation,
Yes.
well, depends. If you have a consultation and you're someone who needs a transplant quickly, I'm not sure there's going to be much benefit of getting a single shot and going for a transplant a month later. If you're going for a discussion about a transplant, you may one of these individuals who a transplant is something foreseeable down the line, months or even years later, depending on what it is, then I definitely would get the vaccine. But remember, having a consultation about having a transplant is not the same as having a transplant.
Okay. Okay, someone wants to know if it's possible that the effectiveness of the vaccine will depend on whether or not you have CML. So will having CML affect how efficacious the vaccine is?
That's a reasonable question. I think the only way I can answer that is CML patients in chronic phase do not appear to be more susceptible than the general population to various infections. And as something I showed you earlier on, they don't seem to be more susceptible than the general population to getting COVID. Is there any reason to believe that there will be less of an effect of a vaccine for COVID? I don't think so. We don't see it with flu. Would COVID vaccine be any different? Perhaps some because of some of the, well, I don't know if it'll be different in CML patients in the general population in terms of that. We're dealing with some new ways of generating vaccines, which are really unique and very interesting and have been wonderful as how fast the vaccine has come out there. And remember, these are not new techniques. Some of these techniques for generating the COVID vaccines have been around for a while in an effort to develop vaccines against cancer. So some of these vaccine preparatory mechanisms have been used on people for many years now.
Okay.
So my feeling is CML patients should behave the same way as normal patients, would be my conclusion.
Okay. And if you've had COVID-19 and you've recovered, should you be vaccinated?
That is a great question. And I'm not sure the answer to that. I'm wondering that probably there's going to be some research coming out too and looking at immunity in people who've had COVID. We do know that there are some individuals who have had COVID for a second time. There have some been reported from Hong Kong and some been reported from the States. And it appears to be because there is some kind of variant in the second infection that they've had. And the second time around, it doesn't seem to be as intense as the first time around. Will vaccination add anything to having had COVID itself? I don't know the answer to that. We have really rare occasions where we actually entertain doing something like that. And the one case that comes to mind is the shingles vaccine. Mm-hmm. We give the shingles vaccine to people who previously have had chickenpox, because shingles is really chickenpox that reactivates in a special way in those individuals. But a shingles vaccine now protects those individuals who have had chickenpox and have antibodies against chickenpox. So perhaps in people who've had COVID, the vaccine might work, but there's no evidence to that at this time.
Great. Okay. Okay, and Lamise wants to know which vaccine is better. Is there one that's better for CML patients?
No idea. We don't know which one is better for any type of patients. They've not been compared head to head. The results of the ones being produced in North America and Europe seem to be roughly the same level of effectiveness. There seems to be less effectiveness in the one produced in China and the one produced in the Soviet Union. That's about all I can say.
Okay. And speaking of vaccines, and you mentioned the shingles vaccine, there is a question wanting to know, is it safe for CML patients who are currently taking oral medications to get the shingles vaccine?
Definitely.
And then along those lines,
shingles vaccine is a killed vaccine, is a vaccine that doesn't cause problems. It's a killed vaccine. I give it to transplant patients who are really immunocompromised.
Well, and while we're on this this topic, are there any vaccines that people with CML shouldn't get?
Not to my knowledge. Whereas in someone who's a transplant patient or someone who's on immunosuppressive drugs, I wouldn't recommend a live vaccine such as the traveler's vaccine or the old type of shingles vaccine, the Zostavax, because they're live vaccines. I'm not sure that's the case for CML. I've had CML patients take all the vaccines like, yellow fever, tetanus, typhoid, the kind of things that the traveler. Mind you, no one's traveling right now, but it's not an issue.
Okay. All right. We have a question here that's about education. Is there a plan to have hematologists or oncologists educating patients to encourage them to have the vaccine?
There's no general plan to educate any physicians, to my knowledge, but I think the message is going out from the experts who know something about this vaccine is virtually get almost everybody vaccinated if at all possible. And whether it be specific education groups for hematologists, someone else, I don't think that's going to occur. There's no central organizing structure to do that. But healthcare facilities, healthcare structure everywhere is saying get vaccinated when you get the chance.
So someone's looking for some clarification that the COVID vaccine is not, in fact, a live vaccine.
It is not.
It's not. Okay. Okay, and somebody wants to know whether or not the CML population will be asked to provide data after being infected with COVID-19. Like, is there anyone tracking?
Yes, there is. There is. Depends who you report to, but the major centers across the country are all aware of the ICML database, and there's a form that the physician can fill out. So if you're a patient who is taken care of by someone in a major facility, let that physician know and ask them about reporting it to the ICML, but it's all voluntary.
Okay, we're going to go back to the DNA question for a minute. Now, you mentioned that the COVID vaccine has nothing to do with altering DNA or messing it up or doing something awful in terms of your DNA. Somebody wants a little bit more clarification on that. Maybe you can give us sort of like the 101 on how the vaccine acts in your body.
Well, the vaccine works to stimulate your immune system to target components of COVID, whether it's RNA or molecules within the viral capsule. It does not get into your system and change your body. It triggers your immune system to have cells act against it. But there's a myth out there and that's floating around on the internet that it gets into your DNA and changes your DNA. It does not.
And do you have an
Now,
opinion on?
the only reason people may argue that is historically, if we go back to the original polio vaccine, the Salk vaccine, which was produced in cells in culture and generated things. Those of us, including me, who got that vaccine, because how it was prepared, did contain animal viruses. Now, even now, 50, 60, 70 years later, we have no knowledge that those vaccines have changed anything in anybody.
Okay.
So those are cases where we know there's a possibility that may have occurred. This is not the case with COVID vaccines.
Okay. And are there any groups of individuals or health conditions that should not get the COVID-19 vaccine?
That's a good question, and I don't think the authorities have come out and said anything yet. It may be that people who are profoundly immunocompromised perhaps shouldn't get it, but even transplant patients, bone marrow transplant patients who are immunocompromised, either because they're on medications to suppress the immune system or their immune system hasn't matured. Groups like the EBMT, which is the European Bone Marrow Transplant Group, which encompasses the European transplant centers, has come out and said at the 6-month mark, transplant patients should get vaccinated. Mm-hmm. Now, the people who do organ transplants may come out and say something differently. I don't know the answer to that. The people who are treating autoimmune diseases or treating certain diseases with drugs that suppress the immune system may say differently. I can't speak for, say, the group that treats rheumatoid arthritis, where you're given some of these medications, what they will say. But I can tell you what the bone marrow transplant groups will say, and I can tell you what the CML treaters will say, because I'm involved with those, and the answer is no. There's nobody who should not.
Okay. And can you comment on, this is my question, but can you comment on the recent instances of people who've had allergic reactions and also the Bell's palsy side effect after having the vaccine?
Well, there've been a couple of people. There may be people who have allergic reactions to a component within the vaccine itself, something that stimulates the immune system. I haven't seen it reported as to why those people had allergic reactions as yet, so I can't comment on that. Bell's palsy is interesting. I'm not sure that there's necessarily a relationship between COVID vaccine itself and Bell's palsy. The cause of Bell's palsy primarily seems to be a reaction to HSV, herpes simplex. And it is possible that the people who've got the Bell's palsy, maybe because they had their immune system turned on by reacting to the COVID vaccine, concomitantly had an active herpes infection, and the immune system turned on against that and created the herpes, the Bell's palsy. I don't think that's well understood yet. I'm not sure anybody believes that right now that it's a direct effect of the vaccine. But again, we don't know. We don't have specific cause and effect data.
Okay. So back to the shingles vaccine for a second. Someone wants to know if we've had shingles previously. Would you get the shingles vaccine?
It's a question some of my patients are asking me. Getting shingles the second time is a rare event. I don't think necessarily that 100% of people who've had shingles have immunity against getting it a second time. I think if you're someone who perhaps has an immune compromised state, for instance, you might be a transplant patient and you've had previous shingles or you've had shingles maybe before transplant, getting the shingles vaccine is not a bad idea. I don't believe, although it hurts like hell for a few days after getting that vaccine in some cases, and that may be the immune system kicking in, other than a local reaction. And I've had one patient who had a significant local reaction to the point where they were not going to get the second shingles shot. I think at worst, it may have no benefit. I don't think necessarily in most people have a negative benefit other than it's expensive if you don't have insurance coverage.
Okay. Okay, we have a question about the COVID antibodies. First of all, what do you think about getting tested to see if you have the antibodies? And if you have the antibodies, should you get the vaccine?
Well, first question I'd have is, do you know where you can get tested in anything other than a study? I'm not sure it's something that's being done routinely in Canada anywhere. I know it's being done in some studies. We have some studies going here in Toronto, but to my knowledge, I know someone who wanted to get the result of that test because a lot of us as healthcare workers are actually participating in that study to see what's going on. Someone wanted to know if they had antibodies, and they're not releasing that data. So I don't know if you can be tested to find that out.
Okay. Okay. What kind of side effects have you heard from people who've had CML and had the vaccine? But I'm assuming you don't have anybody yet who's had the vaccine.
I have no firsthand knowledge of anybody yet, so anywhere.
Okay.
And none of my colleagues anywhere around the world have reported a problem.
Okay. And should there be any concern about the vaccine interfering in CML treatments?
No. Remember, see, the CML treatments themselves act on BCR-ABL, a molecule within the CML cell, shutting it down, and hence shutting down the CML cell. COVID vaccines act to stimulate the immune system. People tried for almost 2 decades to get a CML vaccine, not very successfully. So in my mind, if you turn on the immune system, maybe an innocent bystander effect, maybe any residual CML that may be in your body. But they're acting totally differently in totally different mechanisms that I do not see how there can be an interaction in that regard.
Okay. Okay, then another question from the United States, looking for a comment on COVID testing types. So PCR versus the rapid test versus home tests versus the other various testing that we have right now. Do you have any thoughts on, is there one that's better? Apparently, according to... Okay.
I think the best one is the rapid test that will give you an answer, particularly in the case of an exposure very quickly. I think it's of significant value to people who may be exposed, to care workers, to hospital staff who may be exposed. It may prevent them from having to isolate because they just don't know.
Okay.
So for instance, there's moves in my hospital now to potentially consider testing people on a routine basis, both inpatients and staff, just to be sure.
Okay.
And it'll be the rapid test.
Okay. And can we expect the COVID vaccine to affect PCR results?
No, I don't think it will.
Okay. All right. And we have a couple of CML specific questions. How important is it to take your medication at the same time every day?
Well, not exactly the same time. There is some variability, but just to keep up the appropriate levels, we normally recommend trying to take it within a couple of hours of the same time each day. Has anybody done a randomized study comparing someone who takes it at the same time each day and someone takes it randomly at any time that there isn't anything? So I can't really answer that question, but it's generally, for particularly some of the side effects about taking it on a full stomach, empty stomach, things like that, is generally right. And for compliance, taking it at the same time each day. Where that becomes an issue is pretty obvious with people who have jobs where things are not consistent in terms of timing. And for instance, shift workers who have issues, it becomes an issue. It also becomes an issue, obviously, in the past where people were doing a lot of traveling, particularly long distances between time zones about taking it. But we don't seem to have noticed more issues in those individuals than the ones who take it regularly. So I'm not, it's dogmas take it at the same time. If you don't, it will make a difference. No idea.
Okay, and then we have a question about medication storage in terms of temperature. How important is it to be at room temperature? And I think this question pertains to having the medication delivered. So if it's sitting outside in the freezing cold, is that going to affect the effectiveness of the pills?
No, probably not. I would doubt it.
Okay, and risks of secondary cancers. Is there any latest research, any new studies on whether or not our medications or the disease itself puts us at risk for secondary cancer?
There's a couple of groups that have looked at that. There was a suggestion from Sweden that perhaps there was a slight increase of some rare lymphomas, but I'm not sure anything's come out. I'm seeing CML patients who, in the pre-TKI era, would have probably died from their CML within about 5 years or something like that. Are now 10, 15, 20 years out, and they're getting breast cancer and prostate cancer and other cancers. So is it at a higher frequency than the general population? It does not appear to be any significant difference to the point where we notice it.
Okay. And have you heard of any new treatments coming down the pipeline?
Well, beyond the ones that are on the market, well, there's a new type of drug that is coming out from Novartis called asciminib, which is a myristal inhibitor, acts as on a different site on the BCR-ABL binding site that seems to have some activity in people who have failed previous treatments. Novartis is going to hopefully get it on the market for certain indications soon. There's studies going as to whether it may help in first line, whether it may enhance the chance of being able to stop. So there's studies in that regard. There's a couple of other TKIs that are being studied. There's one from China that's going into phase 2 and 3 studies. So a couple of other drugs that are very early. Are there other types of drugs being studied right now? Possibly, but not very far along in terms of treatment.
Okay.
It's tough right now to do CML studies, and the reason is people are doing so damn well on the drugs that are out there. We're not finding a lot of patients who are compliant with their medications, who have got resistant disease to the point where you can put them on studies. That's something we all like to hear. I'm not saying there aren't some, but they're rare events.
Mm-hmm. Okay, now I have a question about, so someone's writing in and says that his BCR-ABL has been at 0.003 for the last 9 months. And he's asking if it has prognostic value. And I guess he's asking if that's good news.
That's great news. But let me let you in on the secret, which may make some people happy and disappoint some. The evidence, there's some studies out there that indicate if you take the 2-year mark after treatment, if your percent reduction is 1% or 2 log, 0.1%, 3 log, 0.01%, 4 log, 0.0032, which is 4.5 log, is the target. So 3 is even a little better than that. The survival of all those individuals at the 2-year mark, if they stay on treatment, is exactly the same. So prognostically, it's great. If that's sustained for another few years, another couple of years, and you have the option for a properly monitored discontinuation study, someone would like that would have about a 50% chance of being successful.
Okay, well, great. Let's talk about stopping treatment. Is there anything new in that arena?
Well, I guess the bottom line is that if you reach the proper standard for stopping treatment, which is around 4.5 logs or 0.0032% of the international standard, sustain that for at least 2 years and been on treatment for at least 3 or 4 years, the chance of being able to successfully stop is about 50%, regardless of what drug you use to get you there. And this is primarily for frontline treatment, first line, and possibly second line treatment, but the only studies have been done with nilotinib, dasatinib, and imatinib. We expect bosutinib will be the same. Ponatinib, which is used in a different set of circumstances, may be totally different. So that's the first thing. There was a mathematical modeling paper that came out about a year ago from Australia, which suggests that maybe monitoring every 2 months may be enough. I think the big item that at least I face in Ontario is getting remunerated monitoring done. And part of the issue is most recurrences are within the first 6 or 7 months after stopping. And we know that if you restart treatment immediately on stopping, the recapture rate is virtually 100%. But if you delay restarting, it's much slower and you may not recapture to the same depth. I haven't got approval yet for that. It has to be reimbursed. In Ontario, it's only reimbursed for every 3 months. I know in some places across the country where the labs are smaller, the patient population is smaller, people are willing to do it, it is being done. But Ontario right now, it's not being remunerated. And that's an issue. I was close to getting some negotiations with the provincial government, and then 2 things happened. Unfortunately, the individual I was negotiating with passed away from health problems, and then COVID hit, and things like this are on the back burner. So, when and if COVID ever settles down, it can be reapproached, but that's where it is.
Okay. Has anything changed regarding your view of cannabis? Oh, this is going to be fun.
Not a thing. Not a thing.
So still no. No.
I've had a couple of people have had some reactions. Some toxicities. So
fair. Okay, what about bone marrow biopsy? Do you think it should be done every 6 months?
No. Not if you've got good molecular testing. There should be a bone marrow aspirate biopsy done at diagnosis. And the reasons for that is there are some people who will have unusual chromosomes that need to be documented at the beginning. And there's some people who may actually show up with more advanced disease that's not obvious on the peripheral blood. They may show up with things like fibrosis. So a diagnostic bone marrow, I believe, is absolute, and it's not being done everywhere. I know people are being diagnosed on a molecular test. If you get good molecular testing, it doesn't need to be repeated. I believe it should be repeated once at roughly a year and a half after starting treatment, if the molecular response is at least 3 logs. And the reason is, and I just had a patient like this last month who showed up with new chromosome abnormalities in Philadelphia chromosome negative cells. And these are not because the drugs have caused this, but because the CML cells probably had a growth preference. And now when I've killed off the CML cells, these other clones grow up. And this individual will be at risk for getting another disease called myelodysplasia, acute leukemia, and that person needs a bone marrow transplant. It's rare, 2-3% of the population. This is not done very routinely. The other time bone marrow should be done are in cases where someone is not behaving appropriately in terms of their response. Either they're refractory in their terms of the response, or they show evidence of losing the response, and you can't relate that to a compliance problem, then I really think you need to do a bone marrow at that time to look at the state of the bone marrow, and also look to see if there's been evidence of clonal progression, meaning new chromosome abnormalities appearing in Philadelphia chromosome cells. But routinely doing it every 6 months and a patient is responding to treatment, no way. The only people who should be having that done are in cases where you don't have access to good molecular testing. And I don't believe that's the case in Canada anymore.
Okay. Is there a CML medication that's safe for pregnancy?
Interferon.
Okay. But there aren't any new ones?
No, not to our knowledge. All the tyrosine kinase inhibitors appear to be teratogenic. And that's a problem. Okay. Interferon seems to be successful, and I've now had, not just for CML but other disease, I've had about 20 pregnancies in patients on interferon. It's good. One thing that's really scared me, there have been 2 manufacturers of interferon available in Canada. One is Roche, and their regular interferon is no longer available in Canada. The only interferon available is Pegasus, which some insurance schemes and provincial plans have not approved. The only other manufacturer was Merck, made 2. It made something called Intron and another one called Peg Interferon. And Merck is discontinuing production of both of those in about 6 months' time, and they will not be available anywhere, which will leave interferon one type available in Canada, which would be the Pegasus, perhaps Roferon available by bringing it in from outside. So that is an option, and women who want to become pregnant or are diagnosed by pregnant is going to be somewhat limited.
Okay. Is there a way that our group can help to stop that from happening? I mean, isn't choice better, or do you think it's okay just having the one?
Look, interferon is a limited use drug. You're not going to tell Merck International not to stop producing interferon. You're going to have no impact there. Where you might have an impact is to looking at provincial reimbursement insurance to try and make sure that at least Pegasus, which is the slow release Roche product, will be available to women in a situation like this in places like Ontario, as no other drug will be available. Part of the problem is, for instance, Ontario Drug Benefits, and that's what I'm most familiar with, that unless a company actually asks for approval of their drug for a certain indication, it's not listed. So getting approval is very difficult, and you have to fight for it on compassionate basis. And when it's not listed like that, getting it on compassionate basis becomes very difficult. If it's not approved or available in Canada at all, then you have to go through the SAP program through the federal government of bringing it into the country. Then it becomes a different issue is whoever reimburses you for your drugs, whether it's private insurance or public insurance, will they reimburse an SAP drug? And that becomes a real issue.
Okay.
I haven't had to fight that battle yet.
Speaking of reimbursement, there is a question wondering, how do we as patients help advance the timeline for approval for timely monitoring of TFR?
I think you just have to complain to the provincial government about this. Now, I was making some sense in the fact that not so much that it was good for you to stop, but I actually was making the case on the basis of a business case, in that the price of monitoring was cheaper than the cost of drug. And since, at least in Ontario, roughly 2/3 of the patients in the province get their drug courtesy of the provincial government, there was a business case for being able to stop a group of patients. Now, remember, if you take 100% of patients at diagnosis, the number of patients who can successfully stop down the line is maybe 20 or 25%. So it's not everybody, it's only a minority.
Okay. Okay, well, we're out of questions, but I think I'll give everyone an opportunity to send in their burning questions. We have one. Is apodasatinib as effective as Sprycel? So the brand.
All I can speak for is my patients in Ontario, where virtually every insurance company, unless you had absolute platinum coverage in the provincial government, all mandated a switch. Now, it's a joke in many ways because there's only one generic available in Canada. At least in Ontario, the price of the generic is still about 85% of the cost of Sprycel. So it's not a major saving, but it's a trivial saving. I have not seen a loss of response in any of my patients who had to switch, and the requirement for a switch was made in, I think, about 6 or 7 months ago here in Ontario. So I've not seen a loss of response. Now, where there have been some changes are the following. Bristol Myers has stopped its support. So people who are getting co-payments from Bristol Myers totally lost that. The Apotex does have a support program for their product. So that can be available. And there have been one or two people say that they have a side effect with the APO. I'm not going to tell people what that side effect may be because everybody's going to start saying they have that side effect. But most of my patients have not noticed any difference in terms of it.
Okay. So the next question is, if you tend to get pleural effusions, does that make you more susceptible to pneumonia or COVID?
We don't think so. The pleural effusion, which is primarily seen with dasatinib, although it can be seen with all the drugs. Let me emphasize that, all the drugs. Any of you, for instance, who are on imatinib, go look up the product monograph that comes in your it can be on all of them. It's an autoimmune reaction. It's an innocent bystander reaction. It's your immune system, for some reason, is turned on to probably a viral infection and sees something in the lining of your lungs as foreign, and as a result generates this. Now, whether COVID will trigger that, I don't know the answer to that. Of all the people who get pleural effusions, at least with dasatinib, half will potentially get it a second time. Half of those will again get it a third time, depending on whether doses are reduced. Now, there's a lot of data coming out now that reducing dose, particularly good response, the indication for use is 100 milligrams, but a lot of patients, if they have excellent responses, are now doing well on 50 milligrams if they've had a good response. So you can talk to your treating physician if you've got a deep response about the possibility of reducing dose, because we definitely have pleural effusions are less on that dose.
Okay. And what are some of the symptoms of pleural effusion? When should you call the doctor?
Well, when I talk to people who are going, we talk about all the side effects, and everybody hates to get that list of 100. The one thing I tell you, if you get shortness of breath, particularly in situations where you didn't get it before, when you're minor exertion going up a flight of stairs, or uniquely when you're lying down, it's a trigger. It's a trigger to get checked out to see if you have a pleural effusion. And if you have a pleural effusion, remember one thing, it may very well and likely is due to your dasatinib if you're on it, or occasionally due to one of the other drugs. Talk to the doctor treating your CML. Don't let someone doing 1,000,001 investigations, including bronchoscopies and tapping and draining. It doesn't need to be done. It can be dealt with in other ways in most cases. So there are ways to deal with it. Now, the one very unique situation of a very uncommon side effect is the patient who's on a drug like dasatinib has a symptom suggestive of a pleural effusion, and X-ray suggests there isn't one. Those are individuals who need to get investigated with something called an echocardiogram, looking for something called right heart failure. because there's an extremely rare effect called pulmonary hypertension or pulmonary arterial hypertension that can rarely be seen in dasatinib patients that needs to be investigated, starting with an echo and possibly with a right heart catheterization of making diagnostic, because the absolute necessity in that case is to stop the dasatinib and switch to another drug. You must stop it under that situation.
Okay. All right, we have a question about back to TFR for a moment. Is there any research being done to move the 25% success rate?
Yeah, lots. People have tried different drugs. The argument was, does second generation drugs do it? Well, the answer is no. Just combining something else with another drug. For instance, there's some studies being done with combining interferon with imatinib and nilotinib has made a difference. The French have a unique bunch of studies where they're comparing different drugs with imatinib, including some drugs being used in treatment of diabetes to see if you can get it. Part of the reason is the CML stem cell has an awful lot of the target for these drugs, yet it doesn't seem to be affected by these drugs. So the idea is to try and hit these cells in a different way. The latest theory is, okay, well, we'll use the new drug on the block, asciminib, and try and use that in combination and see if it makes a difference. But people are trying. There is research, but nothing has really improved things much above the 50% mark. We do know that the longer you have a deeper response does increase your chances of a successful treatment, but not more than 1 or 2% per year in people now out 5-10 years or more. So it's not big time differences.
Okay. Okay, we have a question about the cost of the drugs. Is there any update on reducing the cost of these expensive drugs?
Well, here's the deal with the cost. Here's the deal with the cost of the drugs is if you got a brand name drug, you negotiate a price, and that's what it is. Generics will help drive the price down, and that can be a big difference, and that varies from province to province. For instance, if we look at imatinib, which is generic Gleevec, the price of 400 milligrams of Gleevec in Ontario is about $4,500 a month. Because there's 4 generics available in Ontario, the drove the price down to $900 a month. But my understanding in British Columbia, which decided they took the 4 generic companies and say, what's your best price? And it drove the price down to $300 for the one drug that they will prescribe. So competition will drive down the price. Nothing else is going to drive down the price. And part of that is related to the only difference is, and I'll get this in a minute, is the base price is in part dictated by our proximity to the United States. Because American pharma does not want Americans cross-border shopping to get a cheaper drug. Although it does happen with some drugs. What we have noticed, for instance, in the price of some of these drugs, is the price remains fairly fixed in Canada. Maybe gone up. Gleevec has gone up, for instance, $4,500 to about $5,000 in the close to 20 years it's been available in Canada, whereas the price tripled in the United States.
Isn't it weird that a drug, though, like it's increasing as the years go by? Why is that?
Well, they brought it up the price because the price of the second generations were there, but the price is all over the map. There's a paper that the MD Anderson group published a couple of years ago now looking at the price of generic imatinibs in the US. And the prices went anywhere from a couple of $1,000s a year to a price of one generic that was more expensive than Gleevec. The American market is very bizarre. Canada, the price is fairly fixed, and the price is not going to bounce around. There may be a little bit of, cost of living increase, but not much more.
Okay. So question about in vitro fertilization. Would you recommend that to someone that has CML once they go off the TKIs?
I presume you're talking about a female?
Yes.
Okay, so I guess once you come off, well, here's the situation. if you're off for a period of time, you could probably try and get pregnant the natural way. If you want to freeze embryos in case you relapse, remember, and go back on treatment, remember it is not the egg that's affected or the sperm, it's the developing fetus. So putting that embryo back into you, if you are on a tyrosine kinase, you again run the risk of the spontaneous abortions and the birth defects. So if you want to do in vitro and store embryos because you may want to consider surrogacy down the line, or you just want to delay your pregnancy, another reason why someone may say their clock is ticking and they want, younger embryos available when they decide to get pregnant down the line for whatever reason. Yeah. But if you're doing it because if you think you relapse and it'll be safe to use those embryos, it'll be the same as if you became pregnant while you're on the drug. It's teratogenic. The drugs affect a developing fetus, so putting an embryo into you would be just as risky. Now, if you were diagnosed when you were very young and female and have not had the opportunity before you started on treatment, that's another issue. You may, after you've come up, but again, if you're fortunate enough to come off treatment and not have it recur, then you could get pregnant in the normal way. I don't see how freezing embryos in that state would make a difference in that case, but maybe I'm missing something.
So if you're off treatment, so let's say you're doing TFR successfully, you get pregnant, and then you're finding that your numbers are rising, or you're out of relapse, or sorry, you're having a relapse. What happens then?
Well, again, remember the most of the relapses occur within, let's say, the first 6 to 9 months after stopping. The number of patients who have late relapses is probably less than 5%. So it's a small number. Okay, so you're pregnant and you start seeing things rising. Well, you could go on interferon if it was available. You could be monitored a little more closely if it's possible, because there's some evidence that perhaps reintroducing a TKI during the 3rd trimester, some people argue the 2nd, I'm less comfortable with that, doesn't have an impact on the fetus. So there are those options.
Okay. All right, so I think we're probably going to wrap up in about 5 minutes. So if anybody has any last questions, feel free to send them in. I do have one here in terms of the genetic. Is it possible that blood cancers are genetic? This person has a number of family members who have different versions of blood cancer. It looks like there's an AML, there's a CLL, another CML. Is it possible that these things are carried in families?
Well, I guess I would like to know, are these first-degree relatives, more distant relatives, or what? Don't know the answer. Yes, there are some families which have these diseases. I've had CML, 3 CML families where siblings have had CML. CLL, definitely there are some family have it. I've had a couple of other cases where there have been several first-degree relatives with different leukemias. And yeah, so there possibly are some families. The majority of people, though, it does not appear to be. But then there's some studies in cancers in general that some very good work that I think has been done at Johns Hopkins in Baltimore, which suggests with people with cancer, roughly 1/3 have a genetic basis, maybe up as high as 40%. Maybe another 1/3 it's spontaneous, in about another 1/3 there may be some environmental impacts, so particularly things like smoking or sun exposure. Do we know that much with leukemias? Not so sure.
Okay. Okay, we have our last couple of questions back to Oh, so switching. So switching from the brand, so Gleevec, to the generic, is that a cold turkey switch or is there a weaning effect? So do you need
No,
to
cold turkey.
slowly...
Cold
turkey.
Cold turkey. Yep.
Okay. And our last question, what is the chance of relapse if you're taking interferon?
Good question. It's there. It's there. And I've just unfortunately had a case in the last couple of weeks. Someone who was trying to get pregnant, went on interferon, has lost their response. If you start the interferon when you have a very deep response, in my experience, I've only had 2 women who've lost the response while trying to try and get pregnant. I've had a 3rd woman who's delayed going on a TKI when they were diagnosed, started initially interferon treatment in order to try and control the disease so she could get pregnant. The disease progressed. On the other hand, I've had probably 15 or 20 patients who have continued on interferon, not lost a response, have been able to get pregnant successfully and breastfeed. So I think if you're starting from a deep response to begin with, I think the risk is probably no more than 10 or 15%. If you go on the interferon and your response is not that deep, it is higher. Let's go back to ancient history and people who were on interferon before there was a TKI. And roughly about 30% of individuals who went on interferon for treatment of CML in those days got a deep response. And in those days, a deep response was cytogenetic negativity. So a 2-log response, perhaps better. We had no way of measuring it any deeper than that. Molecular testing was available. So about 30% got that response. The French group, an individual named Josie Reifers in France did this work. If they looked at people who stopped treatment, tapered the interferon after they'd had about 3 years of that deep response, about half those people recurred after stopping. The other half never went back. And I've got some people who have stopped, and I've got some people who have recurred with interferon, some as late as 8 or 10 years after stopping interferon. So.
Interesting. Well, so that was our last question.
What's also unique, one other point about interferon is interferon controls CML in a very different way than a TKI. It controls it by modulating the immune system. It stimulates the immune system. You know, someone who's interferon may not be someone who should get a COVID vaccine because they may get an overstimulation. Because interferon at one point, there was an attempt to put it in a nasal spray to fight flu because it's an anti-flu situation. And a lot of my patients who've been on interferon commented how infrequently they got the flu until they came off interferon. So it's very interesting. So where was I going with all this? So I think that may be one group of individuals who possibly should not get COVID vaccine, but they're rare.
Okay. Thank you so much, Dr. Lipton. You're amazing, as usual. I really appreciate you taking the time out to join us tonight. We also have another networking session right after this, and the link is posted in our audience chat if you would like to join us afterwards. But thanks again, Dr. Lipton. I hope you have a great holiday. We appreciate your time and you sharing your insights and all your wisdom. It's amazing. Thank you.
So get vaccinated and have a great holiday.
You too. Take care.